Hello, my name is Tahar Benhidjeb. I'm head of surgery. I accepted the request of gastrointestinal endoscopy to participate in the outdoor interview series. The title of our article is Laparoscopic cholecystectomy versus transvaginal natural orifice transluminal endoscopic surgery, abbreviation is NOTES, cholecystectomy. Results of a prospective comparative single-center study. In addition to my full-time position as head of surgery in Abu Dhabi, I'm also the director of the NESA, which is the new European Surgical Academy located in Berlin, Germany. And within the NESA, I lead since 2006, the natural orifice surgery project.
Why did you feel a need to do the study?
The story behind the need to do this study is a personal one. For a better understanding, please let me explain some prerequisites pertaining to natural orifice surgery or NOTES. Nowadays, we are all aware of the benefits of laparoscopic surgery, which include less postoperative pain and a decrease in postoperative abdominal wall complications, e.g. wound infection, hernia formation, and good cosmetic results. All these significant advantages resulted from the reduction of the centimeter-long laparotomy incision to the few millimeter small laparoscopic incisions. Therefore, it seems logical to postulate that no skin incision at all means no postoperative somatic pain, no wound infection, and no hernia formation. And no scar at all means, of course, optimal cosmetic result and physical integrity. And all this is building the foundation of the NOTES concept, which means that instrument used to perform the surgery will enter the body through natural openings like the mouth, anus, or vagina. Our group in Berlin concentrated from the beginning in 2006 on the transvaginal access because of excellent results, postoperative results with this transvaginal approach for more than 100 years. In 2012, I moved from Germany to Abu Dhabi in the United Arab Emirates, and I wondered if I could continue my research on NOTES because of the following given local conditions. First, nobody in the Middle East was practicing NOTES, and there are no NOTES studies emanating from this region. Second, the United Arab Emirates is an Arabic Islamic country. Therefore, how ready and willing would be the population and patients to be ready to talk about the transvaginal access. Third, the Middle East countries are considered more conservative when compared to the Western world. I decided to take up these challenges, and from the beginning started offering to all female patients with a symptomatic cholelithiasis the transvaginal option in an outpatient clinic setting. I explained in detail in Arabic or English both the classic laparoscopic three-port technique and the transvaginal method, as well as taking into account potential benefits. I performed all 226 procedures consisting of 136 laparoscopic and 90 transvaginal cholecystectomies. A single experienced clinician respectively recorded all postoperative data and treatment characteristics of the patients in a prospective manner. The purpose of this study was to prove the equality of transvaginal cholecystectomy and laparoscopic cholecystectomy, as well as to support and underline the advantages of transvaginal cholecystectomy over the laparoscopic technique, especially with regard to post-operative pain.
What does your study add to existing knowledge?
First, we are not aware of any comparative study with such a high number of consecutive and selected cases performed by one single surgeon at one single institution. Second, in our study, the primary outcome measure focused on postoperative pain, and we clearly demonstrated that more than 24% of the patients in the transvaginal cholecystectomy group indicated 0 on a visual analog scale postoperatively, which means no pain at all, whereas only 3.7% of the patients in the laparoscopic group did so. Moreover, more than 25% of the patients in the transvaginal group needed no post-operative analgesics at all. Our results, along with others, confirmed the significantly less pain and pain-free potential of the transvaginal cholecystectomy or approach. Third, during the 24-month follow-up period, all patients who underwent the transvaginal cholecystectomy were happy and satisfied with the surgery. And they also told us that they would recommend the technique to friends or family members. All patients described an unchanged sexual life, and 3 of them became pregnant and delivered healthy children. Furthermore, the fact that none of the women who underwent transvaginal cholecystectomy made use of the offer to consult a gynecologist can be considered as indirect proof of lack of symptoms. Fourth, to the best of our knowledge, representative studies comprising patients from an Arabic Islamic country and with such wide diversity with regard to nationality have not been reported to date.
What should come next?
One limitation of our study is the selection bias with no randomization because of the type of operation was chosen by the patient herself, and this could be a constraint and in a subjective post-operative evaluation of pain by the patient. Therefore, we need large prospective randomized controlled trials in order to assess this potential advantage of the transvaginal cholecystectomy. And the reason why NOTES surgical techniques have not been widely adopted in current medical practice by surgeons, as happened with the laparoscopic techniques, is a question that might be answered by performing surveys involving physicians in general and surgeons in particular. To conclude, NOTES represents a paradigm shift in surgery and the next step in the evolution of minimally invasive surgery. Thank you very much for your time.